All right, well, thanks, Dr. Brady, for chairing this, and Dr. Akhtiari for kind of organizing and kind of the great summary so far. So my part of this will be to discuss kind of the literature and the evidence base on concurrent disorders, concurrent substance use disorders, and depression. Talk a little bit about the guideline and some of the nuances there, and then we'll go back into some discussion at the end. So once again, I'm Victor Tang, and I'm from Toronto, Canada. Okay, and no conflicts of interest relevant to this thing. So, one of the million-dollar questions in the field is what's the difference in the brain and in our patients for a depression of someone that doesn't have other comorbidities and someone that has a depression and a substance use disorder, and whether specific clinical trials and specific interventions are needed specifically for that comorbidity. I don't have the answer to that, but there are definitely trials that select for and try to target specifically that substance use disorder and major depressive disorder comorbidity. Here are two kind of select review papers that kind of touch on this, one of them by our group and one from Heather Ward's group. And I'm going to summarize them here, but good references for you all who want to see the details, because I can't go through every study, of course. And so basically, this is kind of an overview of just studies that we're looking at people diagnosed with a major depressive disorder, and interestingly, a couple studies on dysthymic disorder or persistent depressive disorder. When it comes to nicotine, there was one positive study in a small RCT in 2021, and then there was a handful of comorbidity studies in alcohol use disorder, although virtually all of them, at least the ones listed here, are open label trials, and so these are non-blinded RCTs or single-armed studies. They showed positive results, but of course limitations in the design. And so the basic question, and Hamid covered this better than I did, is that basically, are there shared neural substrates that if you were to target that shared substrate, you would be able to treat both disorders? And that's basically the goal of what these trials try to do. And this is an example meta-analysis that kind of looked at a meta-analysis of fMRI activation for drug cues in addicted patients and negative stimuli cues in major depressive disorder, kind of showing a shared activation of this kind of ventromedial network, basically demonstrating that they overlap in certain brain functions, and in this case, the hypothesis was that the appraisal of value is abnormal, shared in both conditions, but just in a different way. But nonetheless, it's a shared kind of neural kind of regions. This is a review that we did, which was basically looking at what were the parameters of MDD studies and the parameters of AUD studies and what kind of overlap there is. And basically, a lot of the protocols are shared and are the same, showing a lot of positive effects for each of these disorders. And although they aren't head-to-head comparisons, you can see the overlap is very interesting. And again, something that Dr. Akhtiari already highlighted, which was that you can have a similar protocol that's effective in each condition. Now, it's interesting, this kind of substance-induced mood symptoms versus primary mood symptoms, and we kind of did a scoping review a couple of years ago. And what's interesting about a lot of rTMS for substance use disorder trials is they have kind of secondary outcomes of depressive symptoms and anxiety symptoms. And it was interesting to kind of survey this literature, especially since you have a lot of the inclusion criteria specifically excluding for psychiatric disorders or specifically excluding for Axis 1 disorders. Yet when they measure depression and anxiety symptoms, they seem to improve with rTMS treatment. To summarize, most mood and anxiety symptoms will improve with rTMS for substance disorder, even if you can't fully figure out or if you don't think there's a primary MDD. Although further research is needed to kind of disentangle the primary etiology. And to touch upon this important confounding factor in diagnosis and assessment of treatment response, right? So we know that withdrawal management for people with alcohol use disorder will improve mood and energy. We know that if people quit cannabis, their cognition will improve, their affect will improve. We know that opioid agonist therapies alone for people that are trying to quit opioids, they will have better quality of life and energy and mood and things like that. And so this is an important thing to consider when we see our patients that are improving. And if we put a scientific hat on, kind of what exactly is the active ingredient here. So it's important to ensure that also that standard of care substance use disorder treatments are being offered as well. So for example, if these kind of standard treatments for AUD and CUD and OUD aren't offered, they could be offered to also alleviate some of the depressive symptoms we're seeing. Just to note about a lot of the trials that we see, most studies for rTMS-780 do exclude for active substance use disorder, although oftentimes nicotine is ignored. Sometimes SUD trials include people with depression and anxiety disorders. It's more common that it's just excluding these kind of severe mental illness like schizophrenia or bipolar disorder. And it's important that we think about who is being included, especially as Dr. Brady mentioned, that depression is just so common in the general population and what might actually be there. And it's important, I think, to scrutinize these trials in terms of how rigorously they're assessing for comorbid psychiatric disorders and whether they report or even know that they're including depression or not. And then it comes to this question about are we reading an efficacy trial or are we reading an effectiveness trial? Right? And so efficacy studies are important because they control for all of the factors except for the active intervention alone. And so these are usually very controlled settings that are, albeit a little bit artificial. And there was actually a bit of a debate on this in the psychedelics debate earlier today. And although this can be criticized, it's also necessary from a scientific perspective as a starting point. But effectiveness studies are definitely needed because real-world patients just look different than clinical trial patients. Here's a highlight of a couple of interesting retrospective cohort studies. There's a good contingent of studies in the literature which basically looks at real-world rTMS clinics. And when you do that, some of these studies show that, for example, this one, 12% had an SUD history. This other retrospective review of a clinic showed 24% had a diagnosis of a comorbid SUD. And we do actually find improvements in anxiety and depression, which is very exciting and very promising, although we want to see these done in prospective trials. Probably the greatest level of evidence for rTMS is in tobacco cessation. It's got that FDA clearance. And again, just to point out that the exclusion criteria was active psychiatric disorder in the past year, according to the DSM-5.